This is the second case. A 20 years old female, right-handed, married, non-hypertensive, non-diabetic, admitted with the complaint of headache since last 3 months, fever last 3 months, left side weakness that is insidious, progressive, and partial. Can you go back, please, Dr. Hassan, the previous slide?
Dr. Hassan.
Can you go back, please, on the first slide? And left side weakness, insidious, progressive, and partial since last 1 month. Adult consciousness. Cannot be assessed. Cranial examination. Visual and visual field cannot be assessed properly. One fundoscopy patient has the bilateral full-fledged papilloma of grade 3. Pupils are bilateral mid-dilated but equally reactive to light. Extraocular movements are normal. No any facial asymmetry. Hearing is intact. Gag reflex intact. No any nystagmus observed. Left side hemiparesis. That is, power patient has the 3/5. The mildly spastic. Plantar left side plantar is upgoing. Investigations, lab investigations are normal. All blood hematological workup has been done. That is, has no any problem in the investigations. Imaging, this is CT scan brain plane, axial cuts. We can appreciate a very ill-defined lesion in this CT scan. The skull base at the level of the CP angle looks cystic lesion. Next, please. Because of CT scan, a lesion can be appreciated more properly on these cuts. There is a cystic lesion, hypodense lesion at right sided CP angle till that clivus, extending to the clivus. Next. Same lesion is there, but now it's extending further to the supratentorial. This is also the lesion, but when we see at the supratentorial, the cystic and solid portion is there that is involving the ventricles of the C-lateral, causing the compression, extending to the thalamus up to as well as the lateral ventricle of the frontal horn of the ipsilateral ventricles. But very ill-definedly, and we cannot comment on the lesion that how it is extensive. Next, please. Very well circumscribed cystic lesion at the CP angle, infratentorially of the right side, extending to the clivus, compression over the fourth ventricle, displacing inferiorly. T2-weighted, which the pure cystic seems to be, but a little bit the fluid is also there, hyperintense. Next, this is a T2 images, but this is the supratentorial cuts of the T2 weighted. We can appreciate. In the infratentorially, there was a lesion was a pure cystic, but when we appreciated supratentorially, causing the displacement and as well as these are the sagittal cuts. But there's an interesting thing that the cyst is prepontine, most likely. We can appreciate the pure cystic lesion that is posteriorly infratentorially is there. That is also involving the prepontine system. And then extending upward. images, and we can appreciate the mixed density with significant perilesional edema, cystic and solid lesion involving the ventricle.
Okay, thank you, Dr. Etadad. Dr. Shumaila, how do you read this?
Actually, it had been better if I would be provided with DICOM images, because the images which are provided are the ones which the neurosurgeon or the presenting person thought that are important. I just wanted to, look at the continuity of the lesion, because actually there are two components. One is lying in the prefrontal area, and one is lying supratentorially. And if I just wanted to make the connection of both, so I was just struggling with the sagittal images. So if we look at the sagittal images, I was just thinking that probably it is a salar and suprasalar lesion, which is, showing extension upwards and downwards, with some areas of enhancement, which we can see on the axial post-contrast images. Some of the lesion is going in the right sided CP angle, and it is displacing the pons and the brainstem. So, and some of it is going medial to the lateral ventricle, and it is actually a long-standing lesion, although the history is of 15 days. But if we look at the size of the ventricles, it is something I would call acute on chronic hydrocephalus, because the ventricles are dilated a lot, and there is some periventricular seepage along that. So maybe we can think of some suprasellar lesion, and in this case, we should consider craniopharyngioma, probably. Although I'm not very sure about, the imaging is actually compromised. By looking at only these images, making diagnosis is quite tricky. But this is what was coming to my mind, because there are two areas. If you look at the coronal images, slide number 114, we can see that there is continuation of this prepontine component and this suprasellar component. There is a bridge of tissue which is in the first image. There is a bridge of tissue which is connecting these two components. So probably this is one lesion which is showing extensions, and the only thing that comes to my mind is probably a suprasellar lesion like a craniopharyngioma. I would like others to, throw some light. This is what I was thinking about.
Gee, Dr. Shumaila, I agree with you with this two very distinct pathology on MRI. That's what also comes to my mind, because there's nothing else that I can think of, a typical low-grade glioma or even atypical low-grade glioma presenting like this.
Yes.
But if we have only the top part that's girding in there, I would have called it glioma, low-grade glioma, as my first choice. And if it had only the CP angle part, I would have gone more towards epidermoid cyst, like we just had a discussion in the previous one. I don't see a lot of contrast enhancement in here, but the T1 images also show a very dirty pictures, not like CSF kind of picture.
Yes.
That goes more with the craniopharyngioma, as we just had the discussion. So this is a very interesting case, Dr. Dr. Etazaz was presenting it, right?
Yes, sir.
Dr. Etazaz, this is a very interesting case, very unique case. And I would request this case, once you have done the surgery and all that, this case should be submitted to SNI UCO for a quick review and publication. So anyway, so that's what I have in my mind. There are some contrast enhancement areas, if we see in this.
Yes, there are.
Glioma areas,
Yes,
right?
on the last images we can appreciate, especially on the
Right.
coronal slide number 121, we can see some peripheral enhancement.
Right.
Yes.
Absolutely. And then this heterogeneous ISO2 hypo intense signal again speaks of multiple different histopathology coming together. So craniopharyngioma comes to my mind.
Yes,
That
go one slide back, 121, slide number 1. Yes, this one. We can
Yes.
see some enhancement, ring-like enhancement in this
Right.
along its anterior aspect. Yes.
that heterogeneous lesion in the
Yes.
occipital region, which is very unusual for if it was a pure glioma.
Yes, and a large extraaxial component, cystic component going in the cisterns, supracellular component. So all of this goes in favor of this. This is the only thing that comes to my mind.
Ji. Dr. Riaz Raja, your thoughts?
Yes, Dr. Shumala, how you will conclude that the supratentorial looks as an intraaxial lesion and more in favor of the intraventricular, and when it's going down into the CP angle or from changing from the supratentorial to infratentorial, it is totally extraaxial mass. So when we see
Yes, so that is yes, please
when
please
we
carry.
see the images of the CP angle and the posterior fossa, we think this can be a epidermoid. And even when you see the coronal images, you find it is pushes the brainstem, but it's totally extraaxial mass, not the intraaxial. But when you are going into the supratentorial, this is totally inside the parenchyma, ventricle. It's sometimes it looks as a thalamic region lesion, and sometimes it looks as a ventricular lesion. So, any comments?
Yes, that is why I was talking about craniopharyngioma, because when I look at the coronal images, I can connect the two parts, the extraaxial part and the intraaxial part. They show kind of a connection. So it seems that probably there is some large lesion in the supracellular region, which has some component extraaxially going downwards in front of the pons and displacing the brainstem, and some solid component which is infiltrating the brain parenchyma from below upwards. So because the lesion seems to be connected to me, it seems that this is one lesion which has two parts. One of the component is cystic and lying outside the brain parenchyma, and some of it is showing some kind of infiltration along the wall of the ventricle. So I said that this is the only thing comes to my mind. I would have gone for a better superior imaging, or at least the DICOM images of the same scan, because when as a radiologist we scroll images, we make a better connection of different areas instead of looking at the static images. So that becomes definitely it becomes superior to look at that. But when I look at these particular images which you have provided, the only thing that comes to my mind is a craniopharyngioma, because no other lesion can have a cystic extracranial component. A lesion which has cystic and solid component and lying in the supracellular region, the only thing that it can be in a young patient is a craniopharyngioma. I don't think of any other differentials at this point. But obviously histopathology is going to be very interesting, because that will correct me as well.
Right. No, I think that's what you're right. Sagittal दिखाइए इसका फिर से डॉक्टर हसन.
Dr. Atar.
जी. Sagittal. और एक और जाइए उसमें. एक और. There was another sagittal view that was okay. So यहाँ पर जो middle वाला है ना. So here, I mean, again, Dr. Shumala is right. We need to look at multiple images in DICOM format. But in the middle one, it looks like as if this is pushing in. So it is still an extraaxial lesion that has pushed in. But then when we look at the axial ones, we do not see a clear-cut boundary except for in the occipital region. इसमें तो नजर आ रहा है boundary. आगे चलिए. Next one. So here, it looks like as if it is intraaxial over here. But I wouldn't be surprised that this is actually an extraaxial lesion that has pushed inside, and because of the averaging at the margins and all the thing, it looks like an intraaxial lesion. So I, until proven otherwise, I concur with Dr. Shumala on this diagnosis. And we haven't had surgery on this one, right, Dr. Raja?
I have two questions from Dr. Atar. Number first, do this patient needs any shunting procedure? Or second question is that how you will proceed? What would be the ideal surgical management in this case?
Right. So shunting, if we can somehow decompress and open up the pathway, shunting will not be needed. My preference would be approaching it from the Cocker's point on the right side, and exploring it in intraventricular, transcortical, transventricular, and uh, get a, if possible, get a frozen biopsy. If not, then at least look at the gross pathology and proceed with that, because in my mind it will have a very different gross appearance compared to the regular brain. And then as you're going down, and if neuronavigation can be used, you have to get a little careful as we are entering into the retroclavial region, because यहाँ से orientation तो खत्म हो जाएगी when you are intraventricular, and you may suddenly come across a boundary, and I don't know, Lilliquist membrane कितना आपको determine करेगी कि you're crossing the boundary now, but then from there you can extend deeper into the prepontine space also, and decompress that. So I always look at the trajectory. So if you look at the trajectory, this is the trajectory like this. It's gonna get you there. एक और दिखाइए coronal में दिखाइए, और है coronal नहीं. So go to sagittal again, another sagittal, previous sagittal दिखाइए, और दिखाइए. Okay, so yeah, this is good enough. So yeah, in the next sagittal, please. Okay, so if you're approaching from here, transventricular, you get the lesion, and then you have this thing. So just like ETV, you're going in here, and you have to be careful. So when you're coming over here, since you're intraventricularly, you may have a very little 3D spatial orientation. So neuronavigation would help a lot in that one. If you were coming from outside, you will be very well oriented. So just one has to be careful about it, because right here, as the region changes, we are talking about the end of the basilar and its perforators and all that thing. And once we cross that, if we should be able to see maybe the whatever Lilliquist membrane is left over here, we should be able to see that, and that will tell us, and we can then continue over here. I would not go after a complete resection, but at least get some biopsy from here also. What kind of stuff this is? Is this just a fluid that will get sucked out if you're lucky, if it's a craniopharyngioma? And if it is something else, then just get some solid biopsy from here. That will be my choice, Dr. Raja. Do you agree with that? Or?
Second thing is that if you are going for the transventricular, transcortical, and transventricular, can we use only the endoscope, get a very small biopsy, because she's bedridden since months. She is bedridden, so safely we can take little biopsy, confirm it, what type of the tumor it is, and then plan for a radical surgery.
जी हाँ, वो भी एक option है. I mean, it all depends on. I tend to just do it if whenever possible in just one surgery, because अगर तो आपको ये lesion जो है, this is very clear, grossly different than. I will use microscope definitely, and I'm sure you'll use microscope also. If not microscope, endoscope would tell you the difference between this lesion and the other one. I, being a old person, not very good in endoscopy, I will put mini retractors, same size and same size corticectomy as a endoscopy, but then mini very thin retractors, and then go from there and just remove this thing, suck it out as much as we can until we get to this boundary, and then get to over here. In that case, what will happen is that you will perform an ETV sort of, which would then not require a shunt. That will be the benefit, and you have removed as much as you can.
Right.